Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers. Today, medical care in immigration detention. Dr. Katherine Peeler is a medical advisor with Physicians for Human Rights and a faculty member at Harvard Medical School. She speaks with Dr. Josh Sharfstein about the state of health services available in ICE facilities, the rules that apply, and the challenges that persist. Let's listen.
Dr. Katie Peeler, thank you so much for coming to Public Health on Call to talk about medical treatment that is available in immigration detention. It's good to have you.
Thanks so much for having me. I appreciate being able to talk about this topic.
So to start, I just like you to introduce yourself a bit to our audience. This is not a topic that you just started studying last week.
No, that's a great point. I have been involved in understanding the health care and kind of rights to health care of primarily relief-seeking immigrants in the United States for about 20 years. I started off in med school and in residency learning how to perform forensic evaluations, so examining someone to understand how their physical or mental health evidence was consistent with a claim for asylum. And I did that for a long time and taught that for a long time, and then have more so in the last few years moved really into larger scale research to understand the conditions and lived experiences of people in immigration detention in order to shed light on that area and to ideally improve the care of people in those settings.
That's a lot of time working on these issues. And I wonder what themes have emerged. What have you found in studying access to medical care in immigration detention?
Ooh, that's a great question. There are a lot of themes. One theme I would say across all of my research is kind of a theme of inhumanity, people who are seeking asylum not being seen as people with lives and loved ones and backstories and futures, and as a result, being discredited or discounted, whether it be during asylum evaluations or when in immigration detention, not being treated like fully human. Another big theme I would say that has come up is just the really cruel nature of immigration detention and how it's managed and what it does to people. Many immigrants who I've spoken with who've been in immigration detention, many have said how, they're fleeing horrific circumstances from whatever country they left, and being in immigration detention was worse. That's pretty striking for someone to think that something is so dire they have to leave their home country. And then I think another major theme is an issue, which we might not talk about quite as much today, but of dual loyalty. So people who work in these systems, what does it mean to work in a system like that? Particularly if you are someone who is motivated by a goal of caring for people. And I don't think we should paint any group of people with a broad brush. And not everyone who works in immigration detention is the same. And so some people really do want to care for others. But when you have a mandate to care for someone, whether it be because of your professional oath or whatever it is, you also have a mandate to keep costs low, to make a system efficient, to potentially deport people. Those often come at odds, and they cause a lot of stress and strain on the people who are working in those systems.
That makes sense, and I'm sure is incredibly difficult. I want to talk about that stress a little bit and ask you about the standards that are supposed to be there, particularly for medical and mental health care for people in ICE detention. It's not that there are no rules.
Right. No. There are many standards, and I could list off a whole string of acronyms, but I won't. But there are many standards which people can look up freely on ICE's website and on the Department of Homeland Security's website, Customs and Border Patrol's website, or if you're thinking about children, on ORR's website. But Customs and Border Patrol and ICE fall under the auspices of the Department of Homeland Security. And so they are really a Homeland Security operation. They're not a care organization the way the Department of Health and Human Services is, which ORR falls under. And that's important to note that they do have care standards, but again, they also have other Homeland Security standards. And the care standards dictate a wide variety of things. They dictate when you first present to the border or to CBP or to ICE. They dictate a medical screening to understand if someone is acutely sick and needs to be triaged to some medical care. They have screenings to understand what medical conditions and medications you might be on at baseline. They have screenings to when someone enters a congregate setting to screen for tuberculosis, things that are potentially communicable. And they also have guidelines for how people who are being detained can seek medical care if they want it, like what the process is for essentially putting in a request for medical care, mental health care, et cetera. And then they thirdly have guidelines for what to do when there's urgent or emergent needs. So many guidelines exist and policies.
So you probably can guess where I'm going with this. Lots of guidelines. How are they followed? And when people look or talk to people who've gone through this or study the records, what do they find? How well are these guidelines actually implemented?
I would say they're implemented inconsistently. First of all ICE detention centers are not the same. People who are detained by ICE are actually held in jails that subcontract with ICE to make some extra money holding people who are being held by ICE. Some ICE detention centers are run by private for-profit corporations like CoreCivic, and so they have a different motive and different operational guideline, and some are publicly run by ICE themselves. And the other thing I should say is that who the medical care is provided by is different. Some of the medical care in some of the detention centers is provided by the ICE Health Service Corps, which is what it sounds like it is. It's a medical service corps under the guidelines of ICE, and other ones are subcontracted out to whoever is available. And so it's pretty inconsistent. The level of experience of people who are providing that care varies. So, whether or not there's a physician available is pretty variable. At night, oftentimes it's just a nurse. Nurses are wonderful people, but they can't be everything to everyone all the time. So it's very inconsistent. And when you look at documentation, you'll find discrepancies. You'll read a clinic note of a child, for instance. I can think of one where the heart rate was 190 and their temperature was 104, but in the standardized exam it said patient playful. And I just find it, you're a pediatrician, most children with 104-degree fever and a heart rate of 190 don't typically look playful. They're usually pretty listless. And so it's hard to know what is pro forma filling out documentation and what is true medical care. So inconsistent is a theme, I would say.
The dual loyalty issue that you raised must be particularly intense for clinicians who are caring for sick people in the detention facility.
Yeah, I think it can be. There was a great op-ed I encourage everyone to read from now, it's probably 10 years old, by Ranit Mashuri. I think it was in the Washington Post. There was in the back of JAMA, there's often like ads for positions for physicians. And there was an ad posted for a doctor position. And it said something like, you need to be board eligible, not be board certified. And the salary was something outrageous, like $300,000, something like that none of us are paid right out of residency. So there was a clear incentive. And then it said that you had to be loyal to the mission of the organization, which is a prison functioning organization. And so Dr. Mashuri wrote about how difficult it would be to potentially take that job. You have student loans, like you want to pay back your loans. You want to uphold your Hippocratic oath, but you also are suddenly being told to provide by these guidelines of a prison organization, which is not primarily a care organization. So it is really hard for people. And you'll see that also there's past reports by the Office of Inspector General have shown, particularly with mental health care, there's a really large amount of burnout and higher amount of turnover because as a mental health care provider, you have these huge patient loads, very little time, and it's exhausting. And so people burn out and people quit. So it's difficult.
With the increase in immigration enforcement that we've seen, I'm curious what thoughts go through your mind, and in particular, whether there are things you would like to know. Is there a role on at least the medical side for more transparency about what is happening, whether guidelines are being followed, what kinds of challenges are being seen?
That's a great question. I think about a few things with the increase in immigration enforcement. Actually, outside detention, I think a lot about the chilling effect of just general care-seeking habits by releasing immigrants and all immigrants. We've seen people with green cards and who are U.S. citizens being picked up by ICE because of what they look like or who they're mistaken to be. We, meaning Physicians for Human Rights, conducted a survey interviewing clinicians in the spring to ask what they were seeing, and people were not showing up to appointments. They were switching to telehealth. They were not sending their kids in for vaccines. One woman who was afraid of her partner and wanted to get a restraining order was counseled by her immigration attorney not to, because her partner said that if she did that, he would call ICE and have her deported. And so she had to choose between her safety, two different types of safety. So I worry a lot about people not seeking care or seeking care in later stages of disease. And then within detention systems, there's a lot of overcrowding. Again, as I mentioned, there have been many more deaths just in the last 6 months than there have been historically in the same amount of time. If you read the death reports that ICE publishes on their own websites, they're not complete. So, you don't want to guess at what's going on, but many of the things that they describe sound like conditions that had they been caught earlier would have had potential areas for intervention and not led to death. And so I worry about a system that's already stressed, already understaffed medically, now with even more people, with not an increase in medical staff. So the ratios are worse. You have more people in crowded centers. So you're going to have an increase of infectious diseases, which we've seen. There have been outbreaks of COVID and other vaccine preventable diseases. And you're probably going to have worse sanitation. In Chrome in Miami, they now have a tent set up, and there's several tents around the country. And so that is ripe for disease. So I worry about all those things. And the last thing I'll just say is the next natural question people might ask would be like, well, why don't we ramp up staffing or make more beds or whatever it is? And I think the important piece to also put here is that the vast majority of people who are in immigration detention are administratively detained. They are not criminally detained. And so actually the safer option for everyone, both people who are detained as well as the staff, as well as the general public health of the United States of America, would be to not detain people and not put them in conditions that are going to worsen their health, both from a system standpoint as well as from an infectious disease standpoint.
Dr. Katie Peeler, thank you so much for joining me and talking to me about your career as well as what that career has led you to observe these days.
Thanks so much for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.